So 60-year-old male comes to you with sudden onset of unable to lift his shoulder up. So what could be a differential diagnosis? 60-year-old male, normal person, suddenly he has noticed that he is not able to lift his shoulder up. So which nerve? Okay. Besides that, musculoskeletal system, no system in the body works in isolation. You have to first realize this thing. Okay. Every system works in synchrony with other systems. So a symptom which is presented by a patient could be because of multiple factors. Your job is to first of all identify what is leading to that symptom. It could be many causes, but for that patient, particular patient, it will be a single cause. So your job comes in finding out, first of all, finding out what exactly has happened. Whether a musculoskeletal system is actually involved, or a neurological system is involved, or there is something else. Okay? Then only you can suggest a treatment plan. Correct? So, neurological examination in case of musculoskeletal patients, why is it important is because many of the times the symptoms which a patient is having due to musculoskeletal problems, the same kind of symptoms a neurological patient will also present with. Okay, like I gave you an example. 60-year-old male suddenly notices that he is not able to lift his shoulder. Okay, so in musculoskeletal, what could be the cause? Maybe there is a rotator cuff injury or a rotator cuff tear. Okay, because of which there is a discontinuity in the rotator cuff and he is not able to lift the shoulder. That is one of the causes. Or he is not telling you that he has sustained a fall, following which he had a fracture of the proximal humerus, because of which he is not able to lift the shoulder. Coming to neurology, like he said, it could be axial palsy. Suddenly he was doing something, or by default he developed axial palsy, because of which there is weakness of the deltoid muscle. Okay, or it could be because of CNS lesions also. He might be having a CNS lesion. He might be having a metastatic lesion in the brain, which might be presenting itself like a monoplegia. Okay, so your differentials are first of all determined by what are the symptoms. You rule out your differentials based on an examination and the investigations which you are going to order. Many a times when you're doing a clinical examination, many of the things you will be able to rule out. Okay, so that's why examination is such an important part, because just for the sake of a patient unable to lift his shoulder, you're not going to write a battery of tests. First of all, you have to identify which system you're dealing with, whether it is musculoskeletal system, in musculoskeletal also, whether it is related to the bone or to the muscle, or it is neurological symptom. If it is neurological system, whether you're dealing with a nerve injury or you're dealing with something related to central nervous system. Understood? So moving on. So this is what I told you. When a patient presents with a neurological problem, what could be the symptoms? With respect to upper limb, let's talk about it. So upper limb patient presenting with a neurological problem, what do you think can happen? Weakness of the upper limb. Besides that, come on guys, speak up, yaar. Now you are in what? Third first, right? Third two. So you're part 2. So you would have seen patients, no? Or you would have read about patients. Okay, what are the symptoms of a stroke patient? Sorry? What is the mnemonic fast? This is a mnemonic for stroke, no? Which we use to teach general population. Anybody knows? Fast. That is a mnemonic for stroke. Nobody knows. I guess this week is stroke prevention week, I guess. You people know or not? You people are neither technological savvy, not at all reading books also. Okay, so just to clarify, FAST is a mnemonic which we use to tell general population what are the most common signs of stroke and what needs to be done. So F stands for facial palsy. Okay, any patient, any person who notices that some other person is having a drooping or a weakness of the one part of the face, okay, that is one of the signs of stroke. Or he is having difficulty in speaking, okay, then he is having arm weakness or a limb weakness. So A stands for arm weakness, okay. Sudden onset of limb weakness is also a sign of stroke, and T means timing. So you have to rapidly go and meet a doctor to rule out stroke. So that scenario which I told you, a 60-year-old male who presents with a sudden onset of upper limb weakness could be a stroke patient also. This you will be able to rule out only when you have tested the patient, only when you examined him. And based on that, you will decide what has happened. You will confirm it with your investigations, and based on the investigations, if your doubt is confirmed and the diagnosis is established, then you will formulate a treatment plan. Okay. So same way, neurological patients, if a patient is coming with upper limb weakness, it could be because of many things. Okay. So your job is to find out what the cause is. Based on the symptoms, you will first try to localize where is the lesion, whether you are dealing with something which is happening in the central nervous system or it is in the peripheral nervous system. Then the job comes is what is the cause of that, okay, and how it has happened. So that only when you know these things, then only you can plan something which can reverse it, or at least you can formulate a treatment plan which will help the patient in ultimate recovery. Clear? So dermatome and myotome, okay, these two terms we frequently use, especially in sensory examinations. Okay, so dermatome is a part of the skin which is exclusively supplied by a single nerve fiber, okay, at a single level. But this is actually a technical term. Usually you will not find an exclusive region. There are very few areas in the body which are known as autonomous zones, okay. Otherwise, most of the times the nerves which are supplying the particular part of the body, the distribution will be same. So there will be a lot of overlap between, say, S1 and S2. So even if the lesion is in S1, the patient won't have complete anesthesia. He will have paresthesia, means the sensation will be less rather than completely absent. Okay. Myotome means a bunch of muscle fiber which is supplied by a single nerve fiber. Okay. Same way, most of the muscles are supplied by nerves which arise from at least two spinal levels. So even if there is a problem of a single level, usually they will not have complete paralysis. They will have paralysis, means weakness. Okay. Upper motor and lower motor neuron. So basically upper motor neuron lesions. So upper motor neuron means from where to where, if I ask you. Correct. So anything which is causing a disruption in the signal going from the brain to the spinal cord, not from the spinal cord to the peripheral organs. If it is causing disruption of the signal from the brain to the spinal cord, that leads to upper motor neuron lesions. Okay. Anything which is at the level of spinal cord or beyond, means at that nerve level, that is a lower motor neuron lesion. Usually the brain has an inhibitory effect, means it modulates the signals of the spinal cord, and most of the time the signals are inhibitory. It prevents hyperreflexia. Okay, so that's why in upper motor neuron lesions, most of the time many of the times you will find that patient will have exaggerated movements, exaggerated rigidity will be there, the reflexes will be too exaggerated. Whereas in lower motor neuron lesion, where the nerve is involved, once that nerve is damaged, then the patient will have paralysis or paresis, weakness with loss of reflexes or hyperreflexia, means the reflexes will be blunted. So that's how you differentiate between an upper motor neuron lesion and a lower motor neuron lesion. So if the patient is exhibiting signs of an upper motor neuron lesion, then you know that you are not dealing with something which is related to the peripheral nervous system. Then it is something higher up, either it is in the brain or it is in the tracts which is communicating from the cortex to the spinal cord. It could be a spinal cord injury also. Higher level injury can lead to upper motor neuron palsy. Okay, but then you are sure that you are not dealing with a nerve injury, isolated nerve injury. Okay, so that's why these things are important. So when we're dealing with upper limb neurological examination, the only thing which you need to know about is brachial plexus. Okay, that plexus is the one which supplies the upper limb. Okay, so what nerve roots are there in brachial plexus? Bolo yaar. C5 to T1. Then, so roots. Then, after roots, what comes? trunk, then cords, then divisions, and then finally branches. Okay, so you need to know whether the injury is at the cord level or at the division level or at the nerve level or at the root level. If it is at the root level, then the root which is providing distribution to multiple nerves, then all the nerves will have some amount of weakness. If it is an isolated nerve palsy, then only the muscles and the area which is supplied by that nerve will be affected. So that's how you delineate where is the lesion. Whether you're dealing with a global brachial plexus palsy or you are dealing with a cord palsy, means either the upper cord or the lower cord is involved. Okay, so what is the mnemonic? So how many cords are there? C5 to T1, right? So what are the nerves? Posterior का क्या क्या है भाई? लिखा हुआ है वहाँ. Lateral, medial and posterior, no? Axillary nerve किसका है? From where does the axillary nerve arise? Lateral, medial or posterior? Only 3 options are there. Sorry? How many for lateral? How many of you are lateral? Axillary nerve arises from lateral cord. How many of you vote for that? Nobody. Okay. Medial? Nobody. Posterior? Nobody. So it arises in isolation. See, one thing, no, neurological examination you will not understand unless and until you understand the basic anatomy. Okay, anatomy is very critical in understanding neurological examination. Without knowing the anatomy, you cannot diagnose. You need to know your anatomy well. Okay, axillary nerve is part of posterior division, posterior cord. Okay, axillary nerve, radial nerve, thoracodorsal nerve. Then lateral. So median nerve is supplied by both lateral and medial cords. And medial का क्या है? Ulnar nerve. Okay. Then there's lateral cutaneous nerve of arm, lateral pectoral nerve. These are the nerves, superior suprascapular nerve. So that's how you have to know which nerve is arising from where. Based on that, you will decide which cord or root is involved, and that's how you diagnose the problem. Okay. So coming to the general examination, like everything in medicine, it is same. It starts with history. So depending upon what is the age of the patient, what is his occupation, from where he is, what he is eating, where he is living, can give you a clinching diagnosis of what he is suffering from. In case of neurological symptoms also. So why is it important? Let's talk about age. So how does age help you out? Think, guys. Just now I gave you an example, no? 60-year-old male, what will be more common? Stroke will be more common, no? You will not consider stroke as a first diagnosis in a very young child. A 12-year-old child, if he comes to you with an upper limb weakness, you are not going to put stroke as a first DD, right? So that's why age is important. Correct? Then, what about occupation? Does occupation play a role? Or a place of residence play a role? Speak up. See, only if you think, then only you learn. If you don't think, you don't learn. You have to start thinking, start applying your brains. Otherwise, there is no point in us conducting lectures, no? Come on, think, yeah. So what about heavy metal poisoning? Can it present like with the neurological symptoms? Huh? So that is important, right? If the patient is from an area where groundwater is contaminated with heavy metals and he presents to you with neurological symptoms, then what you will consider first? You will consider it as a DD, no? Otherwise, somebody who is using an RO water, you won't. So that's why history is important. Then occupation. Ulnar nerve is known as musicians now. Correct? Median nerve. Why? So see why it is named like that. Now you have to know the reason behind it. So median nerve basically controls the gross movements, not the finer movements of the hand. So laborer basically needs to lift, do heavy manual work, but he doesn't need finer control of his fingers for that. Correct? So that's why it's known as laborer's nerve, because if that nerve is intact, even if the finer movements of the hand are not there, you can perform a lot of tasks. Why ulnar nerve is known as musician nerve? It supplies intrinsic muscles of the hand. Without intrinsic muscles, you cannot do finer movements. Artistic description requires it. If you are a painter, if you play a flute, if you play any fine instrument, if you are a surgeon, you need your fine movements of the hand. Without an ulnar nerve, you cannot do it. Okay. So there is a reason why it is called so. So if a person who is in construction industry, okay, and he is involved in destruction of collapsing the buildings. You've seen people like that, no? So they will use very heavy hammers or jackhammer. You have seen jackhammer? There is a device called jackhammer in which there is a piston which moves very fast, rapidly, and breaks down the concrete into bits and pieces. Okay. So vibrating instruments, if you are using for a long time, then these people, after a certain point of time, have a tendency to develop median nerve weakness. Okay. So if a person is coming to me with from that occupation and complaining to me that he is finding difficulty in moving his hand or fingers, then first thing I will consider, maybe it is related something to the median nerve. Then a sports person who is involved in, say, Neeraj Chopra. What does Neeraj Chopra play? Javelin. So, what is the most common injury he can have? He already got operated for it, Just before he won the gold, in that same year he had the injury, got operated, underwent rehabilitation, went on to win the gold in Paris Olympics. Paris only won. So, rotator cuff injury. Okay. He had rotator cuff injury. So, the occupation of the patient also plays a role in what kind of injury he will have. Okay. A two-wheeler driver who is involved in an accident presents to you with global weakness of the upper limb. For one TD will be head injury. But second most common thing which we regularly find out is brachial plexus lesions. Okay. A mother who brings a newborn infant with the kid not using his hand or not moving his upper limb. What do you think? Brachial plexus palsy. Okay. Previously it was misnomer as obstetric palsy. It is not correct. But brachial plexus palsy is quite common in newborns. Okay. So that's how it is important. Then drugs. Okay. Medical history. If patient is diabetic, he presents to you with loss of sensation. Then you have to check out whether his diabetes is under control or not. If he is uncontrolled diabetic, then he has a very high tendency of developing neuropathy. Okay. Inflammatory disorders. Patients like GBS is there. Patient is giving you a history that he had bouts of loose stools for a few days, and after that he suddenly developed weakness or paresthesia of the lower limbs. Then you will think Guillain-Barré syndrome. Correct or not? Then Bihar, when there is season of this thing, lychee, kids used to have encephalopathy. They found out that there is a toxin in the lychee which you consume on empty stomach. Then the kids have a tendency to develop encephalopathy. You know that or not? Previously, it was a big mystery why during lychee season kids used to suddenly develop encephalitis and encephalopathy, and many of those kids used to die. So then they found out that these kids are usually living in the area where lychee is being produced. So they used to eat that raw lychee because they don't have food. Whatever lychee is there, they will eat those. And if kids consume it on an empty stomach, there is a toxin in that can lead to encephalopathy. So that's how you find out things. When you think, then only you find out. Family history, why is it important? Any role of family history in neurological examination? Sorry? Bol? Hypertension. So hypertension, how is it going to cause neurological symptoms? Correct. Stroke. So if you have family history of hypertension and you have not been diagnosed with hypertension, you can present sudden with stroke, and we find out that you are also suffering from hypertension. Then besides that, Huntington's chorea. Many of the times people don't give that history. Okay? When they have initial onset of symptoms, when they visit a doctor, they might not be giving you the history that they have a family history of these diseases. Neurofibromatosis. These are the things which you have to think that the patient might be suffering from those. Although then you have to ask for leading questions then. Okay. Social history, why is it important? Huh? Bihar. Why? Social history is important everywhere, man. What is Saturday night palsy? So any of you had Saturday night palsy? Nobody has seen the patient also. Sorry? Yeah, you're correct. You're correct. You're correct. Speak up, yaar. Speak up, speak up. You're correct. Nothing wrong. It is described like that only. Tell, what is it? What is Saturday night palsy? It's not brachial plexus, sorry. It is isolated weakness of the radial nerve after a bout of heavy drinking. When you lose consciousness and your nerve gets pinned on the arm of the chair or the back support. Okay. So we see patients like those. So that's why social history is important. If patient is presenting without any, he is not giving any history of trauma, okay, and he presents with sudden onset radial nerve palsy, then you have to ask. It is not mandatory that patient has to consume alcohol. Many times I think you would have yourself noticed that when you sleep, awake from sleep for a long time, you will feel numbness of the upper limb. Why does that happen? Because your nerves get compressed. You will have tingling, you will numbness, you will not be able to move your fingers for a lot of time. And after a period of time, it will recover. Correct? So you people also will be suffering from these kind of things. And these are things which you find in day-to-day life. Many of your relatives will ask, see, I am feeling numbness in the hand. Then you have to tell whether it is actually something alarming or it is something which is normal, which can happen to anybody. So somebody who is saying that while sleeping they develop some numbness of the fingers or tingling which recovers by itself, then you are going to tell most likely it is not nothing else. You have to just change your habitus or change your sleeping position. Correct? So these are the systemic diseases which can cause neuropathy. Okay, like he told, atherosclerosis, which can lead to stroke, rheumatoid arthritis. Okay, rheumatoid arthritis, if it is uncontrolled, it can lead to global spondyloarthropathy. Okay, and then ultimately lead to cord compression and patient present with neurological symptoms. Hypothyroidism, diabetes, cancers. How do cancers present with neurological symptoms? Pancoast tumor, correct. Then most common. Pancoast tumor is quite rare. Correct. That is the most common thing. So many of the times the cancer is diagnosed when the patient develops weakness or back pain. Okay, because spine is the third most common site of metastasis. So then you have to find out those things. So again, first of all, whenever you're doing examination, then first thing you have to rule out is whether patient is having CNS symptoms or PNS symptoms, peripheral nervous system. So in this, the conscious level, the general examination plays a vital role. You have to talk to the patient. If patient is talking coherently, he is having other parts of the limb, he is moving normally, he is able to give you a decent history, and there is no confusion in the patient, then most of the time you will rule out central nervous system disorders. Okay, because a patient whose Glasgow Coma scale is, what is Glasgow Coma scale? Why is it used? Assessment for what? Assessment of consciousness. See, it is basically because for assessing the cognitive function of the patient, no, and CNS. Okay, central nervous system function, whether it is functioning properly or not, especially in trauma patients. So, what are the components? Eyes response, then verbal, then motor. So, what is the maximum score you get? Total score. What is the maximum total score? 15, correct. Eye has how much? Then verbal 5. Motor, correct. So you have to take that. Okay. Then there is mini mental state examination. You know that? For stroke patients, you have to do that. Okay. There is a questionnaire which is given, which will have very simple questions, which patient has to answer. So based on that, you can assess the cognition of the patient, whether the patient is cognitively all right or not. Otherwise, patient, if he is suffering from some degenerative neurological disorder, that helps you in diagnosing neurological disorders. Okay. So that's why general examination is important. So once you have done that, then you come for local examination. So local examination, again, inspection, palpation, percussion, or auscultation also. Okay, moving aside. See, basically you do inspection, palpation, then you do special test. In special test, you check the sensory and motor power. Okay. Percussion per se doesn't have a role unless until you're suspecting any fracture. Okay, if you're tapping on the bony points and patient is eliciting tenderness, bony tenderness, that can be a indicator that patient might be having a fracture. Okay, otherwise percussion doesn't play that much of a role. Percussion plays a role when you are doing a recovery, when you are assessing recovery of a nerve injury. How? There is a test which we do clinically to assess whether patient is recovering or not. That involves percussion. Okay, that is homework for you. I won't tell you everything. Okay. So nerve injury, when you have to assess the recovery of the patient, whether the patient is recovering or not, you have to do one clinical test. You have to find it out. So inspection, again, you have to assess the movement. If you are talking about upper limb, you have to expose that upper limb. You have to see whether there is any weakness is there or not, whether there is any scar is there or not, whether there is any sign of any injury is there or not. If patient is having a bruise on the upper limb, on the arm, with abnormal mobility, and patient is having weakness of the hand, what you will suspect? So many clues. Come on, diagnose. Patient, 40 years, comes to the OPD with a bruise on the arm and abnormal mobility of the arm, with inability to extend his wrist joint. What are you going to suspect? What is Saturday night palsy? Radial nerve injury. So how do you diagnose radial nerve injury? What does radial nerve do? Wrist drop. So what wrist drop is? Effect of the radial nerve injury. It does extension of wrist and fingers. If you are not able to do that, then only you develop wrist drop. No. So patient with a upper limb injury with a wrist drop, what are you going to suspect? A humerus fracture with a radial nerve injury? No. Patient is having abnormal mobility of the arm and he is not able to do extension of the wrist and fingers. Most likely it is traumatic, no? And what does trauma lead to? Fracture and nerve injury. So that's why inspection is so important. You have to expose the patient, you have to find out. Another scenario, patient comes to you with a history of unable to extend his wrist for 3 months. Okay. And he has weakness of atrophy, gross atrophy of the muscles. Then How does it differentiate? Could be stroke, could be something else, but then it gives you a clue that the symptoms which is there, it is long standing. See, muscle doesn't waste in a day or two. You have to realize this fact. Even after nerve injury, it takes quite some time for the muscle to start atrophying, start thinning out. So a person who presents with an atrophy of the muscle, most likely the cause of that problem has been there for a long time. Even though patient might be telling you that sir 2 दिन पहले ही हुआ कि 2 दिन से मेरा हाथ नहीं उठ रहा, but when you examine the patient you find out there is a gross atrophy of the muscles, global atrophy with skin changes, the skin is dry, correct? Then you will think that no, it is not something which has happened in a day or two, it is something which is long standing. Many times brachial plexus patients might come after a long time, they will have multiple, they would have taken opinions from multiple places, but they don't count that for how many days they have been taking those opinions. For them the history remains the same, 5 days back, 5 days back, 5 days back. But then when you ask 5 days means from when, then they tell you sir 5 days means in July I had an injury, after 5 days I noticed that I am not able to do. So for them that 5 days is still that 5 days only, but they don't count that it is now October. So from July, August, September, October, it is already 4.5 months. So 4.5 months of brachial plexus injury, the patient will start showing signs of atrophy. Okay. So that's why inspection is important. Then palpation, what do you see? It is written on that. It is written for your benefit only. Read, what is the first point? Huh? What is tone? What is muscle tone? Tell me, correct? Tell. See, you are allowed to be wrong. This is a class. This is not your exam. You are allowed to be wrong. You are allowed to make mistakes. Only when you make mistakes, you will find out what is the correct way of knowing. No. You are allowed to do it. Speak. See, at least you know something, na? Remaining 30 people don't know anything. So you are allowed to tell. Bol. Resistance against passive movement, that is how you check it. Okay. So tone is basically underlying tension in the muscle, baseline tension in the muscle, which prevents excessive tension in the muscle. Okay. It prevents excessive stretching of the muscle. That is called tone. So again, why tone is important? The first initial slides we had seen, no, I told you something. Correct. Upper motor neuron and lower motor neuron. So upper motor neuron, what you will find out? What will be the tone? Hypertonia. Okay. So when you have exaggerated tone, when your reflexes is exaggerated, then you have ruled out peripheral nerve injury. No, you are dealing with something in the CNS. Simple, na? See, in medicine also 1 plus 1 is 2 only. It is never 11. So you have to think critically. When you think critically, when you collate the symptoms and your examination findings, then you will arrive at a diagnosis, and most of the time you will be correct. Rare scenarios can happen where you might be wrong, but most of the time you will be coming out with the correct answer. So that's why you have to think critically. So when you see, simple, no, one patient comes to you with upper limb injury, he is not able to dorsiflex his wrist or unable to extend his wrist. Then what you are going to do, you are first going to check the whole upper limb. You are going to check the skin. You are going to check the movements, whether there is any fracture is there or not. You are going to check the arm movements is there, elbow movements is there or not, wrist movement is there or not. Then you are going to check the muscles. Okay, because muscle injury itself can lead to loss of movement. Just like I told you, rotator cuff injury. If patient has rotator cuff injury, he will lose the shoulder movement. So even though it is a musculoskeletal problem, it is a muscle problem, but the presentation will be similar to a accident of palsy. Unless and until you examine him, you won't be able to find out. Similar way, a fracture of the proximal humerus, patient won't be able to abduct his arm. He will present the same thing. Only when you palpate it, you will feel that there is some abnormal mobility at the shoulder joint, or you will feel the crepitus of the fracture. Then when you order the X-ray, you will confirm your finding. That's how clinical examination is supposed to be. Okay, so tone is there. Then power. What do you mean by power? Power is power. Strength of the muscle. No. What is the, you assess the strength of the contraction of the muscle. If the contraction is weak, then it means muscle is weak. Although it is functioning, it is weak. Okay. So what are the grades of power? 0 to 5. So can you elaborate? लिखा हुआ है ना वहाँ पे. That's why I want you people to read. 0 means 1 means flickering. Flickering, or at least when you palpate, see when you're checking for power, na, one thing is you have to check for movement also, and simultaneously you have to palpate for the muscle contraction also. So if I'm testing for elbow flexion, then I will keep my hand over here and see whether, first of all, whether elbow is moving or not, simultaneously whether the biceps is contracting or not. That's why palpation is important, because you have to feel the muscle whether it is hardening or not when you're contracting it. Okay, so for one is trace of flicker. So fasciculation you usually don't observe, but you can feel, especially in deeper muscle, but you can feel the contraction of the muscle. Okay. Grade 2 is if gravity is eliminated, then patient can do the movement. So how do you eliminate gravity in upper limb? Next question. How do you eliminate gravity? Suppose you want to check shoulder abduction. How will you eliminate the gravity? Correct. You have to ask the patient to lie down and ask him to move his shoulder. Then against gravity. Then resistance. Moderate and severe. Grade 4 and 5 are there, no? They are dependent on the physician because it is subjective evaluation of the physician who is checking it. So that's why it has to be moderate force, and you have to always compare it with the normal side. Okay. So these in examination should not be taken in isolation, especially when the patient is having a power of 4 or 5. When you are having somebody in which you are thinking that the power is 4 or 5 and you are thinking that the patient might be having a unilateral lesion, then it is always worthwhile to check the contralateral limb also. Check the power over there. Only when you find a difference, then only it is so. Otherwise, if somebody is weak, say a very small child, and somebody like this guy tries to exert a force, he's not going to be able to do it. Okay, so that has to be there. Then sensation. How do you check sensations? And first of all, what sensations you check for when you're doing a sensory exam? Pain, temperature. What is the first thing which you say? Touch. That's the first thing which you check. Okay. Why? What is the logic behind that? Okay, homework. Okay. Find out why touch is the first thing which we check for. Okay, so touch, fine touch and crude touch, 2 things you check. Then pain, as you said. Then vibration and proprioception. Simple. That completes your sensory examination. Then finally reflexes. So what reflexes you check for in upper limb? Correct. Biceps, triceps and brachioradialis. So biceps, which now spinal level you will check for? If you have to tell one, check over there. So this is what I was saying, no? Autonomous zones. So when you want to pinpoint the specific spinal level for which you want to assess the sensation, then there are certain points in the upper limb which you can check. If the sensation is blunted in those regions, then and remaining everything is normal, then most of the time you're dealing with the pathology which is at that particular level only. Okay. So for C5, C6 is the lateral aspect of the antecubital fossa. Okay. C6 is thumb, C7 is middle finger, C8 is ring, little finger, and T1 is medial side. So where do you check in fingers? You know the distribution, sensory distribution of the hand, no? So my question is, where you check? See, the finger is so big, no? So where you will check? Correct, tips of the fingers. You check on the tips of the fingers, not anywhere else. Okay. So done. Okay. Just 5 minutes. Give me 5 minutes. Okay. So what he said was correct. So for biceps, basically you check C6. Okay. Triceps is C7. Then for deep tendon reflexes also we have to grade it. Okay, because you have to differentiate between upper motor neuron lesion and lower motor neuron lesion. So if it is absent or very weak, then most likely you are dealing with a lower motor neuron lesion. If it is exaggerated or extremely high, then it is upper motor neuron. Okay.